We have a lot of experts in the room here from various countries, and I'd be delighted to hear how folks are tackling these issues. I think both Anton and Laura gave examples of the challenges and how in the UK some of this has been addressed, but I'd be delighted if folks could mention what they're doing regarding PrEP, treatment as prevention, what's being done, what's not being done, and to hear from you some comments which we could discuss together. Ventura, any words from you regarding these topics on PrEP, on treatment as prevention? What's your vision for that, for both here in Catalonia and for Europe?
So, you know, I loved one of the last slides you presented regarding the efficacy in real life in California. Because one thing that, it's really, we should see this as a threat, is that when it will become more popular and people will become very used to the availability of PrEP, but you don't set up, I don't know where, a sort of support for adherence to that PrEP, we might be seeing new infections with 184B mutation emerging, and then also that will be a threat even for biotherapy or for other strategies in the world. So this is one concern I have. So far it seems that it's not a significant threat, but in the future could be, unless we set up this, this support, and here in this region where you are, in Catalonia, so we have like 3 new infections per day. And we work, my unit, very in a close collaboration with an NGO, Projecte dels Noms, which is one of the most important NGOs, and is doing a very excellent work in the prevention field and in assessing and in catching or capturing acutely infected gay men, that it's immediately transferred to our unit and they start therapy immediately. But if you don't have these facilities or this structure or these NGOs, how you manage this in different cities? So that's something of brainstorming. I would like to hear your point of views on that.
Okay, interesting points.
How you set up this? For the audience, I don't know. So what? We will be delighted if the audience wants to collaborate with our discussion.
You do also mention this, the collaboration. I mean, your center, I know it well, you have a very strong attachment to the community. So I think I don't know if it was only Barcelona or Catalonia, the government, the hospital, the community, that's very tight. I think that's one of the keys. That's something which might be very different in Alabama and the United States. So I think these are issues also what I think a lot of the work in London, this tight connection seems to be key. I think that might be a key factor, and that's different, I think, in different countries and in different societies. Without that link, I think it's very difficult. I think actually in London there are clinics.
Yeah, Jonathan, I mean, I think every country is going to have to look at what they're going to do. And I think one of the things that I got from the San Francisco slide is if you can get school kids engaged early, it might help. But some countries, not possible to talk about anything to do with sex, right? And other countries, you can start young. So there's different strategies. The UK is very special in a way because we've got this whole network of STD clinics throughout the whole of the UK where people of high risk do come. So we can offer it them there. The problem for us is the people that don't come. All right. So, but that's going to be the same everywhere. But I agree with you, Ventura, that the major issue is to keep thinking about it, and you have to engage the politicians, the community, the physicians and everybody else involved. And I was interested in what Jonathan said about in some places like New South Wales where they've got really good primary healthcare doctors, they can run it really well. That model could be transferred elsewhere where they've got good primary healthcare doctors. But in other places where they don't have that good system, you have to think of a way of integrating it in. And one of the last, just quick comment, one of the big things that is being pushed forward for the global health is a unified healthcare system where we do not compartmentalize too many things. Because as soon as you start saying it's his job over there, it often doesn't get done.
Yeah, but the problem is that these guys are healthy, so they don't go to a healthcare unit because they are not ill. So then and they probably are quite reluctant to have to go to a hospital or a care center because that they feel afraid of that. And then they rather prefer to go some places, some NGOs, but it's not plenty of NGOs willing to deal with that. And how the government set up a facility where young people at risk, they go there to get advice and to get some support and for adherence. It's not that difficult because at the school that's great, that's fine. And as you said, this is tiny school. No, it's only few schools that can deal with that because the majority will not accept to focus on sex. But a part of that, so when you leave the school, when you finish the school, then what happens? So which is when you start having probably more sex.
So Professor Ströbrink, word from Hamburg.
From Hamburg. I would just like to provoke you a little bit and say that I agree with everything that's been said. The problem is in many Western countries, we don't have a high endemicity setting just for specific groups. So if you want to roll out PrEP and give it into the hands of primary care physicians, you have to give them very, very firm guidance on whom to select for PrEP. And this will, I think, most likely not work if you follow the nobody's left behind principle. So everyone who wants should get PrEP because the cost effectiveness is going to go down a lot in settings where there's virtually no risk. We have these worried people who are extremely afraid of HIV, who want to be protected from everything, and I think it would be wise to prescribe PrEP to them. So how do you envision having this rolled out in a low endemicity setting?
I mean, that's a brilliant question. It's certainly one I can't answer, and it's certainly one of the major sticking points that we at home, we spent a lot of time drafting policies and guidelines around PrEP access, and then sadly our National Health Service decided it wasn't their responsibility after all. But that was the major sticking point. How do you define the people for whom it's a cost-effective intervention? And clearly, actually, the cost-effectiveness is as the cost comes down, as we have more and more generic drug, actually could argue that the lower prevalence populations or the lower high will certainly be cost-effective. But I think really that the reality and the experience people have had is that that's probably not going to be an issue. You're always going to have the very worried well. We all have the people who attend for regular HIV tests who really aren't at high risk. But actually the majority is what they found in PROUD, and I think the same is true for Ipigate, is the people who presented asking for PrEP by definition were very high risk of acquiring HIV. Now that may change as the acceptability of PrEP and the safety of PrEP and knowledge about PrEP improves. You could argue that only the high risk people knew about PrEP and knew to ask about the trials, but I think we risk worrying too much about low risk people attending for PrEP, and therefore we are denying PrEP or potentially denying PrEP to those who are at high risk. So I say we just have to cross that bridge when we come to it, and I think based on what I have observed and heard, it's unlikely.
I mean, just one brief sentence. I think we all agree on this point. I think the problem is we are encountering resistance from third-party payers with this argument. And we have very little more than our conviction to the topic.
Yeah, but we have all the data. We have all the data about who are included in the trials from all of the data that we have. So Jean-Michel in IAS put up some guidance about who might have PrEP, right? So it's strong enough for me to say your blood pressure is normal, you don't need antihypertensives, right? So we also have to be strong on our side. Your risk of HIV is so low, I'm not prepared to write this prescription. We've had it with sleeping pills. We've had it all sorts of stuff that patients put pressure on us. So why is it when they've got a risk of HIV that's, they're in a permanent relationship with someone who's HIV negative but worried that their occasional once a year they may go somewhere, right, and do something that they shouldn't do? That's such a low risk, unless they're injecting drugs or, they're seeking out bad behavior, high-risk behavior. Therefore, you have to just be firm. And I think we have to say to the payers, we have to be given the responsibility about who we're going to give PrEP to. We've got a huge database now of all sorts of people who have been given PrEP, and we can make that judgment. They don't argue with me about the hypertensive budget or the sleeping pill budget because they trust me. And I hope they trust all you guys too, that you're not going to get pressurized into giving PrEP to people who do not require it. And I think that's the only way I can see that we have to be a bit of a gatekeeper, or the primary care physician does. Otherwise, what's all of our training and everything else that we ever done worthwhile?
So here, number 2, and then we'll go with the back.
Udi Davidovic from the Amsterdam Public Health Service. Just as a comment, because you've invited us to write some comments about our approach now in Amsterdam. About 3 years ago, with it was an initiation of Joep Lange, we started what we call the H team, HIV elimination team, where we actually teamed up all the key players in the field of HIV to work together and divided our work in 5 work packages. One was actually promoting PrEP, and we have a demonstration trial, but also 2 harm reduction programs that are being developed now, similar to what Anton has presented, until our government decides what they're going to do with reimbursement. The green light from EMA helps us to actually disseminate that fairly smoothly, excuse me. And the second package would be is actually promoting treatment as prevention. A third is promoting awareness to acute HIV infection. The fourth one is actually the one that is being very relevant one, is actively working within the field to reduce barriers for acceptance of PrEP or acceptance of direct treatment. And the fifth is a study about direct treatment in terms of functional cure aspects. So what we're trying to see is that you have to work multidisciplinary and try to enroll everyone in order to, each one does its bit, but the goal is common. I just want to give you one example of such a success. We've launched a year ago awareness program for acute HIV infection. The idea is to create a push from the people themselves instead of a pull from the professionals. Professionals were very poor in identifying acute infections. And what we have actually managed to do, we've erected a website where people could actually go online, fill in the risk behavior in the last 2 weeks, and also the kind of symptoms that they have. They would get a recommendation whether they are or not at risk for an acute infection. They would be referred to our STI clinic in Amsterdam, where we had a Cepheid machine that we could establish an acute infection within a week, and then on the same day they were on pills. Wow. So actually we had a campaign which within 8 months 150,000 people visited, of which 80,000 actually started a symptom check, which is an interactive questionnaire, and finished it. So we're talking about 80,000 people. Wow. Of which only 3,000 got the recommendation that they should get tested, of which 600 or 700 actually came, which resulted in 10 acute infection detections in 8 months. We have initially figured that we'll have to have 100 tests in order to find one acute infection. We actually found 10 with 160 tests. So this is the kind of approaches that if you do chip up together, you can actually make some impact. 10
infections that you're preventing, obviously, you're also preventing a lot of transmissions, and that's very impressive. Thank you. Microphone 1, continue.
From London. I'm really interested in 2 points going back to the risk assessment. One of the things that we talk about a great deal, and both Laura and Anton have alluded to, is the issue of HIV testing, that we have numbers of people who are living with undiagnosed HIV, and we are promoting HIV testing as a major thrust across, I think, many countries across the world, and particularly in England. However, I would suggest that we are not using those HIV negative tests properly. And so we are not doing the risk analysis that Anton is talking about, that will lead us into ensuring that people who are at high risk are actually being prioritized for such interventions as we have, because the discourse is about making the diagnosis in people who are undiagnosed, as opposed to preventing the diagnosis from being acquired in people who are at high risk. So I'd really like to know, how do we reframe the testing discussion, particularly as we put tests into the hands of more and more non-specialists, and we promote that? What will happen or will we actually have the opportunities to ensure that those people who test negative, that an HIV negative test is seen as itself a diagnosis for those people who would be able to benefit from PrEP. And I think my second point is going back to how do we implement this. And actually, if we think back the parallels in our country, at least, between contraceptive provision and PrEP, here we have sex with a risk. For contraception, it's sex with a risk of pregnancy. Here we have sex with a risk of HIV. We have methodology for ensuring that women who are at risk of pregnancy have contraception. Surely we can make sure that those people who are having sex with a risk of HIV can have the mechanism for having the same prevention. So those would be my two queries, I guess, to the panel. How do we deal with the negative tests, and how do we ensure that risk of whatever the risk of a sexual act is prevention or protection is available?
Yeah, so I agree completely with the second point. With the first point, the problem with HIV testing is if you're negative, you go, phew, that's great, and you might not change any behavior or do anything else. And I was quite interested in what you're doing in Amsterdam, because you could easily, I mean with the home kits, and I'm not sure if in the home kits it's got any risk stratification questionnaire where it says, look, this one might be negative, but you have an X risk of developing HIV, like you do with coronary care risk, you know, the Q risk 2 or the other Framingham's and all that, right? And you can say with your current behavior or at the behavior that we think is the highest risk in the last year that you'd fill out, please make sure that please go and see someone or go and get some help or counselling, or these are the online resources. So that sort of stuff should go on. I think just saying, oh, great, you've had a negative test and walk out the door is a totally missed opportunity for us to do good public health. It comes back down to your point, though, who's going to do all that, right? Because, but you don't need, as I say, a post-grad doc who's been in the field 20 years to do that at all. You can easily train people who are better at it than we are, because we're all too busy rushing, thinking about the next patient.
And again, obviously, Jane, I totally agree and echo your points. But I mean, it's always been a challenge, isn't it? That actually, the more we promote testing outside of core services, and for us at home, most tests used to be within sexual health services. Actually, still most tests are, but actually, it's probably about 2/3, 60% now, and others are in A&Es. But I think what we risk, and of course, the ideal is that the negative test is accompanied by a discussion about risk, etc., and risk prevention. But by making things too complicated, we have to remember that by this period we had when offering an HIV test was fraught with concerns about, do I need to do counselling? Do people need... We still get questions like, do people need written consent for an HIV test still now in this day and age? So I think we need to be careful about not overcomplicating the HIV testing process, and therefore having the emergency and primary care physicians and community services going, actually, Joe, what... So I think what we need is something really simple and something as broad as possible. So that may be a European web page that we all agree on. We can write it today. You can get those little URLs, can't you, that instead of typing in a huge, great long thing, it's just hivtest.org, or doesn't even need to say HIV. And so every time someone has an HIV test in Europe, they get a sticker with that little URL. They get a text. They get a text message to their phone there and then, and it takes them to a page that offers the absolute minimum that we'd like to offer. And that's something that's simple. It doesn't frighten the test providers. Patients can choose to click on that link or not. And even something as simple as that, I think, will go a long way without overcomplicating something that we actually want to roll out more, not discourage. So,
yeah, your HIV risk score, yeah.
Microphone 1, another comment?
Hi, good afternoon. Steve Harris, I'm from the States, from Miami, Florida. And we have quite a large HIV population, per capita population in the Miami-Fort Lauderdale area. And I've been involved in the care and treatment of HIV really since monotherapy with AZT, going back, so seeing quite a bit. Currently, today I'm really involved, kind of edging over into co-infection with hepatitis C. That's kind of my focus these days. But just talking about PrEP and TASP, if you will. I mean, certainly there's no arguing with the data. The data that's been around for the past 5 or so years really proves out on the screen and in clinical practice. I think the issues that we really deal with are more of a cultural issue, and really for a number of different things, if you will. I mean, certainly we know that HIV and AIDS is a disease of disproportionalities, if you will. Certain communities and demographics seem to be greater affected than others, certainly in the States and certainly in the South Florida area as well. And just to talk about it for just a moment, certainly we have issues in the African American community. in that there is a general distrust of the healthcare system, number one. Number two, when we talk about the African American community, it's not just African American blacks, but we have a large percentage of Caribbean blacks as well living in the South Florida area. And indeed, on the AM radio dial, broadcast in Creole, there will be individuals preaching on the radio that don't take your HIV medication. We have shamans that you can come to and visit, and they will treat you with spells and potions and beads and whatever it is, and you will be gone, HIV will be rid of you. And we really do need to kind of reinforce this with our population, number one, in terms of our Creole population. Number two, in terms of the youth population, another disproportionate share as well. I mean, I have overseen medication adherence groups for at least 15 years, if not longer as well. And these are individuals that are in their late teens, 18, 19, 20, 21, et cetera, who have never lived without HIV and AIDS being around and part of the community as well. Whereas I can remember when I was in school, when Lincoln was president, I mean, I can certainly remember, first there was the outbreak of herpes, and then, certainly HIV came on the scene after that, and we didn't really hear much about herpes after that. But going back to the young and the youth, they believe either on the one hand, and this is the MSM population, the young MSM population, on the one hand, I'm going to get the infection anyway, so what does it really matter how I practice and what rules I play by? Or the other misconception is, they have a pill now that cures it, don't they? So what's the issue as well? So we need to work on addressing those issues as well. Also, I'm a big believer in testing initiatives. Getting the word out, know your status, get tested. If you're positive, get on meds. If you're on meds, stay on meds. Be adherent, 95% of your meds, et cetera, and getting that word out. Lastly, along those lines, is that in dealing with either government committees that I sit on or working with the PWA associations that I work with as well, when I started working with these communities 15, 20 years or so ago, I was extremely surprised at that point that the HIV/AIDS activists will know as much about the science and the medicine as those of us sitting in the room today. And I think it's important to contact and bring those people in, and they are more than willing to work with you because they are a trusted group. Again, in the young group, in the MSM group, they will listen to them and believe what they preach, sometimes a little bit easier, or there will be a little bit better uptake than there are from us who are in the clinics as well. So I think that's an important group to go out and meet as well. Thirdly, in terms of, we talked about, or at least it was presented on the screen and heard about this as well, that with the uptake or with the association of PrEP or TASP, that there is no change in the condomless sex practices. Well, I will be honest with you that I don't know anyone on PrEP who still utilizes condoms. And indeed, if you did utilize condoms, the barrier method of contraception, a latex condom, we wouldn't really have to talk about these issues as well. So when we say there has been no change, I'll buy into that, but I have no one in my practice that's on PrEP that still uses condoms. And I know the date on the screens, not just these screens I'm familiar with, these are the registrational trials, if you will, very familiar with all this data as well. I've seen no change in really the use of condoms as well. Lastly, in terms of the actual treatment and the prescribing of PrEP, I think there's a couple of things to talk about. We talked about the cultural issues. We talked about the age issues. Two things I want to talk about are the actual providers, and certainly a big issue in the U.S. is insurance providing or paying for these services. In terms of the primary care providers, I think one of the most important things is to have people treating HIV, whether it's active disease or it's PrEP or whatever it might be, to have providers treat who know how to provide and treat. And I think that a primary care provider, one of the best things that they can do is to refer to an experienced ID, infectious disease, or someone who treats HIV in large enough numbers that they can treat. And most in the South Florida area, because of the high per capita population, because of the high HIV population, because of the high awareness, will know who the providers are to go ahead and refer to. And they are well known, certainly in the HIV positive community, and certainly through the referral network of their peers on who to go to, because many of the providers themselves are part of the MSM community. And as we say in these circles, they're partying with them over the weekend and sitting in their waiting rooms on Monday to be treated by them as well. So that trust is automatically there and apparent and allows for a good bridge. Lastly, in terms of insurance, which are big issues in the US, and certainly with the advent of the Affordable Care Act or Obamacare, I will tell you that 3 years ago, when ACA or Obamacare was first the law of the land, if you will, there was what we termed sticker shock when individuals went to the pharmacies to pick up their prescriptions for medications that they had been on for many years and now found that their co-pays, which used to be $5 or $10, were now hundreds of dollars. So that provided sticker shock. That is beginning to change. A number of plans now are having either separate risk groups where these meds are tiered to a point where there is very low or no copay, and that's opening the door as well. And also in terms of PrEP, more insurance companies are beginning to understand and allow that.
Great.
So
I think we'll let Laura address
Sorry.
some of those
Yeah,
issues.
oh,
Those
didn't
are
mean
all
to talk so
all
much. I
important
apologize.
comments. And Laura, there were some of that you addressed.
No, I'm not going to do some.
Thank
Definitely
you.
not all. And so there's just only two. Your first point about the communities and perhaps where this incorrect information, I assume it's incorrect and that these people can't cure HIV, the incorrect information about HIV treatment. And we've had very similar experiences at home, and actually Jane next to you has got more experience than I have. But the thing that's echoing throughout, and actually you almost answered it yourself further in, is community, patient activists, peer support. And I think when there is misinformation or fear within a community, the best way to fight that is from within that community, not from outside. So it's no good us doctors going, they're wrong, the treatment works. You need people from within the community, and that's where skilling up peer support workers, peer information, HIV positive people from the same community talking about their experience of treatment and et cetera, that's how to fight it, is empowering. And we're very dependent, and quite rightly so, on a fantastic community and peer support network, as many of the people here, I'm sure. And the only other point I want to pick up on was the rising rates of sexually transmitted infections and the impact of PrEP. And I think you're absolutely right. By definition, anyone who uses a condom consistently often doesn't even want to consider using PrEP anyway. And it's certainly a battle we're facing, because we have two issues in terms of cost and access. One is the drugs, of course, but the other is our services. And for us, that's our sexual health services and their fear about an avalanche of STIs and people coming to clinic. But the reality is STIs are going up anyway. We don't have any more than a minuscule number of people on PrEP, and syphilis and gonorrhea are rocketing in MSM at home. So it's our fear now is as soon as we introduce PrEP, that will then be blamed, but it's on a background of this. So the STIs are going up anyway, and at least we can make sure that one of those STIs isn't HIV, and there probably will be a small increase, but then it becomes about that balance of a small increase in treatable bacterial STIs, counterbalanced by the fact you've got a dramatic reduction in HIV.
So we're going to...
I spent quite a lot of my time just addressing what you were saying about education and community. One thing, just one example, we sent some medical students to schools to talk about HIV, and the youth evaluated them as very highly impactful compared with older people who go there. So it is so I mean, in essence, if you know your epidemic and know your problems, you find the solutions to them, right? And your problems in South Florida are going to have some resonance with our problems, but you're also going to have them very different. And we all have to know that. Although we call ourselves, we're still in Europe, every country and even every city might have some different problems that you have to try and address and find a solution for. And the solutions are there. We got antiretrovirals out to 17 million people in the planet, right? We can get PrEP out to a lot more.
So we're going to have to take a break. Ventura, want a final word?
Final comment. What really concerns me is also that a part of the significant increase in STIs, bacterial STIs, so we should try to also implement the vaccination for HPV in all our young population, because otherwise in the coming years, decades, we are going to see significant increase in cancer related to HPV. And this is so far not well implemented, at least in this region. I don't know in Europe, but
Yeah, well,
this is
HBV vaccination.
Yeah,
the
I mean that
needs to be absolutely.
no,
Yeah,
it's the
HPV.
one I mean,
Yeah,
HPV.
Okay, HPV.
So we're going to need to
It's
give you guys
PB,
some
yeah,
coffee.
that's my
so
English,
we're
you know.
we're gonna this discussion will continue. We have another day and a half. A few notes before folks leave. First of all, I want to thank our speakers and our co-chair. This was wonderful. And this is the beginning of a discussion which will continue.